patient blood management is to understand that to give someone a transfusion is not without hazard. Yes, blood is relatively safe now in terms of transmission of viral disease, but there are an emerging number of outcomes from transfusion that may be deleterious to the patient in the longer run. We're trying to make sure that the patients have an optimal blood volume and red cell mass. We're trying to minimise blood loss, and perhaps most importantly, we're trying to demonstrate that patients who are anemic can cope with that and don't need to be treated empirically with a transfusion.
PBM is a combination of different therapies. It is not any one single effort. It combines from the moment the patient sees their doctor, their general practitioner, out in the community, all the way through to the post-operative care as well. So it is all-encompassing. It isn't just not transfusing. It isn't just reducing transfusion. It isn't just reducing the trigger in which you transfuse. It's all these things combined, as well as appropriate anemia care, appropriate therapeutic care, and appropriate post-operative care.
But in the majority of circumstances, we really are trying to reduce bleeding, reduce anemia, reduce blood transfusion. So we try and figure out what a patient needs, not what is normally done, and so we try and de-standardise care and individualise it.
It's my strong belief that with the multiple elements outlined in the patient blood management program, if you start to do some of the simpler ones, then you can make a difference and start to see some benefits. I think one of the most important things is to educate clinicians about the elements of a patient blood management program. And it's intuitive that if patients lose less blood, we're going to be less likely to transfusion. So surgical hemostasis is a no-brainer. Optimising patients' hemoglobin before they come to elective surgery, again, common sense. It's not too hard to implement programs. That just requires some reorganisation.
In the balanced state, 1 to 2 milligrams of iron enters and leaves the body each day. Most of the body's iron needs relates to the daily production of around 200 billion milligrams.
I'm Catherine Robinson, a haematologist and medical consultant on this e-learning course. This algorithm outlines a recommended approach to the diagnosis, investigation and management of iron deficiency anemia across different patient groups. Although it is presented as a flowchart, it is important to keep in mind that investigation of the underlying cause of iron deficiency and initiation of iron therapy are parallel strands of care. History and examination are critical components in the assessment of anemia and must not be bypassed. Once you have identified a patient as anemic, that is, they have a hemoglobin level below the laboratory reference range, Always look at the red cell indices and blood film comments, which provide important clues. The ferritin level is the most useful indicator of iron status. A low ferritin level confirms the diagnosis of IDA. A ferritin level above 100 makes IDA unlikely, and a ferritin level between this makes IDA a possibility. The clinical context and other laboratory results, including blood film and inflammatory markers, need to be considered together, seeking expert advice when required. Once the diagnosis is determined to be consistent with IDA, go back to the history and examination with more specific questions and considerations based on the likely underlying causes specific to the clinical context. It is likely that at least some of these were not considered in the initial patient assessment. Determine from the history any sources of overt blood loss and consider symptoms and signs of underlying pathology that may be associated with occult blood loss. The underlying cause of iron deficiency must be established in all patients. Importantly, in men and postmenopausal women, and also in some premenopausal women, evaluation for benign or malignant GI lesions, inflammatory conditions such as inflammatory bowel disease and peptic ulceration is indicated. Screening for celiac disease should be performed. Iron therapy is initiated to restore haemoglobin level and replenish stores while determining the underlying cause of iron deficiency. Oral iron therapy is an effective first-line strategy for most patients. IV iron is indicated for selected patients. This algorithm is used in conjunction with other tools and resources provided in this e-learning package, including interpretation of iron indices, iron therapy, and patient information. Let's use this algorithm to assess the case of a 79-year-old man being reviewed in cardiology outpatients for long-standing angina controlled with medical therapy. His current haemoglobin level is incidentally noted to be 104 grams per litre, consistent with anemia. The reference range for the laboratory for men is greater than 135. The MCH is reduced at 24 with a raised RDW and film comments consistent with iron deficiency. Although the MCV is just within the normal range at 81, it has been falling over time along with the haemoglobin level and MCH. The haemoglobin and red cell indices were all normal 18 months previously, consistent with an acquired cause rather than an inherited cause such as thalassemia minor. A ferritin level was added on to an existing blood specimen and was found to be 42 in the presence of a raised CRP. In this case, the patient fits into the middle box of possible iron deficiency anemia. However, based on the clinical context, IDA is highly likely. An elderly man with raised inflammatory markers and red cell indices and blood film suggestive of iron deficiency. The clinician was helped to this conclusion by looking at the interpretive comments present on the blood film and iron studies. There was no history of overt blood loss, and occult GI blood loss was the most likely cause. Oral iron therapy was initiated and the patient was referred to a gastroenterologist. The GP monitored response to therapy and ensured appropriate follow-up. Always look at the blood film and iron study report comments for interpretive assistance and seek expert advice if unsure. Providing meaningful clinical comments on the pathology request form will help improve their value.
The important thing really with treatment, once you've confirmed that the iron deficiency is there, even for instance if they are going to have to go on to have a endoscopy, gastroscopy to sort of sort out the cause, it's really important not to wait until they've sorted that out, but to start the patient on treatment because the first line is usually oral treatment and it's very easy and cheap to actually give to start with. And if you're already treating that patient while they're having their investigations done and they're responding to the treatment, the patient will be in a better position if it does turn out that they're going to have surgery. It might be that their haemoglobin's already increased over the couple of weeks that are actually happening until they've finalised their investigations. The other thing about therapy is certainly monitoring that there is a response and getting the patient to understand that it's not just a couple of weeks. If they're genuinely iron deficient with very low stores, it is going to take 3-6 months at least, and that's presuming that the actual cause of their blood loss has been managed as well.
Mrs Robson is a 42-year-old mother of 7 children, aged between 18 months and 12 years.
Intravenous iron unfortunately has got a bad name. I'm old enough to know of the old days of Imferon, which was a high molecular weight dextran, which had significant adverse side effects. And I think many older clinicians still really think that intravenous iron is a no-no. There is a definite role for intravenous iron, certainly in people, the small percentage of people who really cannot tolerate the oral iron, cannot absorb it because of reasons to do with their gut.